Most people who lose a tooth think the hard part is over once it heals. The extraction is done, the socket closes up, life moves on. What almost nobody tells you is that the moment that the tooth comes out, something starts happening underneath the gums that has nothing to do with your smile. Maybe you've got a gap you've been meaning to deal with. Maybe you pulled a tooth a few years ago and figured you'd get to it eventually. Or maybe you've been watching a parent lose teeth one by one and everyone keeps saying it's fine, as long as it doesn't hurt. This video is for all those situations because what's actually happening in each of them is the same thing. I'm Dr. Tim Batita. I am a dentist, a medical physician, and an oral and facial surgeon. Being trained as both a dentist and a physician, I treat thousands of patients who come to me after years of being told a missing tooth wasn't urgent. What I see in those cases is vastly different from what they understood they were told. And the part that surprises people most isn't what's happening in their mouth. It's where this process ends up if nobody intervenes, because it doesn't stay local to the mouth. I'm going to walk you through exactly what happens inside your body when a missing tooth goes unreplaced, while most dental visits don't touch the surface of this, and what the right next step actually looks like. Point 1, the bone underneath that gap is already changing. Most people assume that once a tooth is out and the socket heals, the area is stable. Done. The gums are healed and it's closed. It looks fine and there's no more pain. The assumption is that nothing is happening because nothing is visible. And many do not spend a lot of time correcting that assumption at the extraction appointment because there's no more emergency at that moment. This belief came out of how dentistry had been practiced for a long time. The dentist's job was to solve the immediate problem in front of them, extract a tooth, and manage the healing. Then later, after the healing was done and complete, get the patient a denture. What happened to the surrounding bone over the following months between the extraction and denture wasn't part of the conversation because nothing about it feels urgent on the day it starts. The bone underneath your teeth is living tissue and it stays dense and strong for one reason: to support the mechanical forces of chewing for your teeth. Every time you bite down, that pressure travels through the tooth root into the jawbone and signals the body to keep that bone strong and healthy. The moment the tooth is gone, that signal stops. The bone starts to resorb. In the first year after an extraction, you can lose up to 25% of the bone volume in that same area. And it doesn't really announce itself. There's no pain, there's nothing to see. It just slowly, silently resorbs away. The bone starts changing the week the tooth comes out. And here's what that actually means for your face over the following years. This is the part most people have never seen explained. The jawbone isn't just structural support for your teeth. It's what gives the lower third of your face its shape. When that bone starts to shrink, the face changes with it. The distance between the nose and the chin shortens. The cheeks lose their underlying support. The lips start to fold inward. People describe looking older in a way they can't quite explain and usually attribute it to age. Often it's bone volume, and this happens whether you wear a denture or not. The denture can actually accelerate bone loss because a denture sits on top of the gums and applies gum pressure, which causes the bone to resorb away. Dentures do not replace the tooth root. Dentures do not keep pressure off of the gums. The bone keeps going away regardless. The patients I see most often in revision cases aren't coming to me because the original surgery was done poorly. They're coming because by the time they decided to act, the bone that would have made everything simpler was already gone. We can still help them, but we're working with much less than we had to start. But the bone is only the first part of this, because what happens to your body when chewing becomes compromised is a chain reaction that most people never connect back to their teeth. Which brings me to my next point. Point 2, the food you stop eating is the food your body needed most. People who are missing teeth or wearing loose dentures adapt. They find what works and stick to it. Softer foods, easier textures, things that don't require much force. Most people experience this as a practical workaround, not a health event. It happens gradually enough that nobody notices the shift until the restricted foods list becomes pretty long. This is the adaptation trap. It doesn't happen all at once. The steak gets dropped first, then the salads, then raw vegetables, whole apples, corn on the cob, anything that requires sustained chewing force. At no point does a doctor sit across from a patient and connect the narrowing diet to what's happening in their mouth. Those two conversations happen in completely separate rooms. The foods that require the most chewing force also happen to be the most nutritionally dense. Hard vegetables, whole fruits, lean proteins, nuts. These are the foods that become difficult or impossible when chewing is compromised. What replaces them tends to be softer, more processed, and calorie present but nutrient light. The calories are there, the building blocks the body actually runs on are not. This is an empty calorie diet, high calories and low nutritional value. The food you stop being able to eat is exactly the food your muscles, your brain, and your immune system depend on. Protein is what the body uses to build and maintain muscle. When dietary protein drops because chewing becomes difficult, muscle mass follows. And muscle mass is not just about how strong you look. It determines your metabolic rate, your immune function, your ability to recover from illness, and your fall risk as you get older. Grip strength, which tracks directly with muscle mass, is one of the most reliable predictors of longevity in people over 60 that medicine has discovered. It is not a number anyone connects to their teeth, but the pathway runs straight there. My own grandmother was told at the age of 90 that she was too old for implants. She was given a denture instead. It was loose, uncomfortable, and she eventually stopped wearing it completely. Immediately after giving the denture, she was limited to soft foods, things with the consistency of mashed potatoes. She lost muscle mass, she lost energy, she stopped getting up from her chair. I was too young at the time to connect what I was watching to what was actually happening in her mouth. When I became a surgeon and started treating patients in the same situation, I understood it. The nutrition went first. Everything else followed from there. There's one more piece of this that I want to get out before we talk about what to actually do. And it's the one thing that my medical training made visible in a way that the dental training alone wouldn't have caught. If you're finding this useful, hit subscribe. This channel is specifically for the things that fall between dentistry and medicine. The questions that don't get answered because one specialist isn't talking to the other. There's a lot more here. Point 3, how to tell if this is already affecting someone you care about. Maybe you're watching this for yourself. Maybe you're watching it because someone in your life, a parent, a spouse, someone who insists they're fine, has been dealing with missing teeth for years, and something about it has quietly started to worry you. You haven't been able to name exactly what changed. You just know something is different than it was a few years ago. There's a cluster of changes that tends to show up in people with significant unreplaced tooth loss. None of them look obviously dental from the outside. Together they form a recognizable picture once you know what you're looking at. Here are the questions. Has the person's diet gotten noticeably softer or more restricted over the last couple of years? Do they avoid certain foods without really explaining why? Have you noticed a change in the shape of their face, particularly in the lower third? Do they look older than their age in a way that's hard to attribute to anything specific? Have they lost muscle mass, energy, or physical stamina that their doctor has chalked up to aging without a clear underlying cause? 2 or 3 yes answers doesn't make tooth loss the only explanation, but it makes the mouth worth examining seriously before assuming this is just what getting older looks like. A lot of what gets attributed to aging in people over 60 has a nutritional component. A lot of that nutritional component has an oral health component, and oral health is one part of that chain that can actually be addressed directly. Which brings me to the piece that surprised me most when I started putting the research together with what I was seeing clinically. And this is where having an MD alongside the DDS changes what's visible. Point 4, the systemic connection your dentist and your doctor are both missing. I trained in both systems, and what I can tell you is that the communication between dentistry and medicine, specifically around what happens to the body when oral health breaks down, is almost non-existent. Your physician probably did not ask how many teeth you're missing at the initial screening. Your dentist probably did not order blood tests. The mouth gets treated as its own separate system, but the mouth is connected to everything. There are decades of research linking poor oral health, specifically chronic infection from gum disease and failing teeth, to heart disease, stroke, diabetes, Alzheimer's disease. The mechanism is likely inflammation. When there is active infection in the mouth from a diseased tooth, from advanced gum disease, from bacteria colonizing the spaces around loose or failing teeth, that infection produces inflammatory markers that circulate in the bloodstream. Chronic low-grade inflammation is one of the primary drivers of cardiovascular disease and the neurologic changes associated with dementia. This is not a fringe claim. It is in mainstream medical literature. Your doctor just doesn't ask about your teeth, and your dentist doesn't know your lab results. There is a protocol in dentistry that already accounts for this connection. Before oral surgical procedures in patients with certain heart valve conditions, the dentist prescribes antibiotics per the latest protocols. This is because bacteria from your mouth can enter the bloodstream and travel there. What doesn't happen is that same level of attention for everything else. For lower grade chronic infection that someone with multiple failing teeth or active gum disease is carrying every day without knowing it. We need to stop filing a missing tooth or failing teeth under dental stuff to deal with eventually. If there is active infection or significant bone loss happening in your mouth right now, that is a medical issue to check out. It belongs in the same conversation as everything else affecting your inflammatory load. Ask the question that neither your dentist nor your doctor is currently asking. What is happening in my mouth, and is it connected to anything else going on in my body? That question is worth asking to both your dentist and your physician. So with all of that on the table, what does a real path forward actually look like? Because the answer is more accessible than most people assume, and it's where I want to leave you. Point 5, what the right next step actually looks like. Replacing a missing tooth with an implant does something a denture cannot. It puts a root back into the jaw. The titanium root replacement relieves the general pressure on the gums from the force of chewing. Because an implant has a tooth on it, it eliminates the need for a denture and the generalized gum pressure that is caused by a denture. Implant-supported teeth keep pressure off the gums, thereby eliminating bone loss caused by generalized denture pressure. Most importantly, with a stable tooth that functions like a real one, the dietary restriction that eliminated food options now has a real solution. I have treated patients in their 80s and 90s who were told they were too old, didn't have enough bone, or were too sick. I have given those patients stable bites and real chewing ability and watched their energy, their nutrition, and their quality of life change within weeks of the surgery. The changes are not cosmetic, they are functional, and they compound quickly once the mouth is working the way it's supposed to. The decision to replace a missing tooth is not a cosmetic decision. It's a decision about what your body gets to work with for the next 10, 20, 30 years. That's a very different way to think about it than I should probably get this fixed someday. And I strongly believe it deserves to be thought about in a medical sense, causing increased longevity. If you've been sitting on this decision, or if someone you care about has, here's where to actually start. Write down every tooth that is currently missing, failing, or being held together with something temporary. Be honest about the number. The numbers matter more than most people realize. Ask yourself whether the food you're eating has changed over the years. What's harder to eat now? What have you quietly stopped ordering? Get specific. If you've been told you don't have enough bone, or that you're not a candidate, or that you're too old, book a consultation with an oral and maxillofacial surgeon, specifically a specialist who does this work with enough experience. What one provider can do and what a specialist with expert training can do are often two completely different things. Bring the systemic question into your next doctor's appointment. Tell them what's happening in your mouth and ask whether it's being factored into anything for your medical treatment. Most of the time it isn't, but it should be. If someone you care about has been declining in this conversation for years, show them this video. Sometimes it takes hearing it from somewhere outside the family. My grandmother spent the last years of her life stuck in a chair eating soft foods because a loose denture was the best anyone offered her, and because nobody connected what was happening in her mouth to what was actually happening in her body. I became the surgeon I am today because of watching that. I treat patients her age and older every week. The options that did not exist for her exist right now. They just require someone to ask the right questions first. The next video on this channel goes into the biggest lie in full mouth dental implant treatment. It's linked in the description and it's on the end screen right now. I'm Dr. Tim Batita. Stay healthy, share your smile, and I'll see you in the next video.